All right, let's get going. We'll get started here. The topic that we have this week isn't all that lengthy, although it can sometimes be annoying. I know it's definitely annoying to go through it. But reimbursement, so how do we get paid? You know, you guys are working your tails off to get into the profession. Eventually, it'd be nice to have that pay off for you and start collecting money to be part of the profession. So here's our objectives. We'll come back to those. I think the tough thing about insurances and how we get paid, we'll look at the history and all that in a minute, but it's just a different language. So reimbursement means payment. So why don't we call it payment? Like, well, because insurances like to make things more complicated, because the more complicated and more confusing it is, the more that we get to say, I don't know, just it's fine. Do whatever you think. So in the early 1900s and before then, healthcare was just that you'd give a chicken to, that you'd plow his fields for, or whatever. It's just the barter system. But as industry changed, people decreased their own production of goods, but then they had money to pay for services and other products, including healthcare. And then here's what I think is probably the most fascinating thing about our healthcare system in modern era. In World War II, there was a need to recruit women into the workforce because a large population of the large percentage of the men were at war. So health insurance was created as a tool to attract more women into the workforce. So come work for us, we'll pay for your health insurance. So that's kind of wild how that's where it started, and now it's evolved since then. 1965 Medicare. Medicare was created. Medicare is the federal insurance for older people. So that has played a big role into our healthcare. But costs have steadily increased for years and skyrocketed in the 1980s. Why that inflection point in the 1980s? Increased specialization of medicine. So no longer do we have the town doc. We have your primary care that calls up other specialists and say, hey, dermatologist, this person gonna go see you for skin. Hey, cardiologist, their heart problem's gonna go over there. Orthopedic, go over there. So instead of the one doc doing it all, that primary care is now the orchestrator of going to these specialists, which is also a good thing. Like, nobody can be good at everything, although I try and I get pretty close. It is good to be specialized. We would get better care, although the cost associated with those cares goes up too. Increased use of technology, definitely more expensive technologies. An MRI machine's real expensive compared to an X-ray machine. It's a lot of good that it can do, but that's part of the cost. And then the aging American population. There's once we start living longer, well, who uses more health care? Older people or younger people? Older, so that's why the costs are going to be higher as well. So who finances healthcare? Individuals, employers, and governments. Insurance companies do not finance healthcare themselves. They just put forth policies and process payments along with assuming some risk. So risk is how likely is something to happen. So, who has a higher risk of heart attacks, older people or younger people? Older. Can younger people? Yes, definitely. But by and large, so the health insurance companies assume some of that risk. So here's some of the language that is purposefully confusing. So first party system is our traditional system. I pay you and you do the thing for me, whatever that thing might be. So the individual, the person seeking healthcare would be the first party, and then the second party is the medical provider. The third party system is where the first party, along with either employers or government, pay an insurance company. That's the third party. And then the third party pays the second party, the provider. It's no different than your car insurance, actually. Right? Car insurance, you guys are younger than me, so your insurance costs are probably a little higher than mine. Right? Why? Because the risk of younger people is higher than older, middle-aged, I should not older. Because then actually it goes the other way. Older you get, you kind of get a rebound effect of having. Um, so if you get into a fender bender, you could pay the repairs out of pocket. That's first party system, right? Or you could call your insurance company and say, I got to do a fender bender. You're going to have to pay for this. And then the insurance part is going to pay the mechanic in the body shop to fix it for you. And they're going to say, well, then they get to monkey around with the other things they get to monkey around with. So it's no different. Healthcare is no different. I will say in the last few years, there's been increased use in the first party system due to the prevalence of high deductibles and flexible spendings and health savings accounts. Um, Deductibles are so yes, I have insurance, but I'm responsible for the first $5,000. That's the deductible, right? Just like our car insurance, there's all have deductibles too. Homeowners insurance, same thing. So 15 years ago, when I started practicing, a $5,000 deductible would open your eyes. You'd say, wow, that's a high deductible. Now it's extremely common. So if you are towards the end of the year, because it resets every year. So if you're towards the end of the year, if it's October, November, you haven't spent a dime on healthcare yet, and you've got $5,000 deductible, and you just sprained your ankle, but you won't like opts to pay cash for that physical therapy instead of having your health insurance pay for it. So there has been an increased use of the first party system. And the other thing about that is health savings accounts and flexible spending accounts are pre-tax dollars. So usually if you have a high deductible health insurance plan, they also say, yeah, but we'll give you this flexible spending account where we'll save money in this special account that's pre-tax dollars. So anytime you get pre-tax, it's good savings. So if you've got $3,000 of your flexible spending account that has to be spent on healthcare, and if you don't spend it, it disappears. All right, well, I'm just going to use that money, and that's basically just acting like a debit card. So anyway, that's the first party versus the third party, how complicated it can get. So like I said, the language of insurance is, the more you can understand the language and their games, the better we can advocate for our patients and also for our employers and for us. I want my company to make as much money. If I'm going to be seeing a patient, so in home care, right? So I go to the patient's home. I want my company to get reimbursed, paid as much money as they could possibly, ethically and morally, right? But I want to make sure they get paid as much as they possibly can because they're the ones paying my paycheck, right? So it's up to us to understand the insurance game because then we get to advocate for our patients, get more visits when the insurance says no, I don't want to give you any more visits. We have to advocate for ourselves or our employers to say this company is not paying us enough. We need to get paid more. So the big thing I will tell you is in your careers, this isn't a fun topic to learn about, but it is crucial. And the better we can play the game, the better it'll all happen. I've tried to fight insurances before and it never goes well. But if you learn the game, then you can have a pretty fair success. So here's a good example. I've got patients, a lot of my patients, older adults, chronic diseases, chronic problems. If you've got Parkinson's and have had a fall, well, both of those things are going to get worse over the next 6 months to 10 years, right? So that person we can always justify, oh, you need more physical therapy, you need more physical therapy, because they're never not going to fall. If I saw them for 4 months in a row, the insurance company would call me and say, what do you think you're doing with this person? What haven't you fixed in the last 4 months that you think you're going to fix again another month? The game, though, is if I see them for 6 weeks, then I take 2 months off, then I see them again for 6 weeks, then I take 2 months off. Now I have very different episodes of care. Now that person I get to see 6 months in a year, where if I tried to do it, I would never be allowed to see somebody 6 months straight. Right. So that's part of which patient is going to get better for longer. Well, if I can see somebody 4 or 5 times a year for 6-week intervals, that person at the end of a year is going to be pretty good. Versus if I see somebody for 5 months in a row and then not again because we've exhausted all their insurance benefits. Now that person at the end of the year is now going to be declining for the rest of the year. So, the more we can learn the game, the better. So individual purchase insurance is where the individual pays the premium. Premium is how much the plan costs directly to the insurance company. Very expensive, not very common. This is something that grew to be a little bit more popular since the Affordable Care Act or Obamacare. The most common is employer sponsored, or what's also known as group insurance. So that's the most common form. So, when we're looking at jobs, we say, well, it's the pay and benefits. Well, part of the benefits is health insurance, should, or else you're not really working at a great place. The bigger the group, the better the deal is on the insurance. So, teaching at CCRI, the health insurance is a pretty good benefit because the state of Rhode Island is the largest employer of the state. There's Brown Life, what used to be Lifespan, is the second biggest. So the state of Rhode Island gets a really good deal on, and it's very, very competitively priced. I don't have to spend in comparison to when I was in just private practice and getting health insurance through the private company that I was working for. It was a lot more expensive because it was a smaller group. Anyway, the cost shifts away from the employer and the government to the individual. So in 2009, the employer contribution was around $3,500. In 2019, around 6,000. But the employee contribution in 2009 under 10 grand, and then over 5 grand in 2019. Obviously, those numbers have rose even more and more. So it's expensive, and whether it's the employer, and the state of Rhode Island as my employer does it, they want to shift costs away from their pocket and into mine. You pay more, no, you pay more, no, you pay more. And the government will do the same thing. We'll talk about the government entities as well. Addition of deductibles and increasing amounts of deductibles. So again, the individual pays the first part of money before the insurance starts paying in. Why do you think that started happening? Why do you think deductibles started? Why do you think insurance companies said, oh, here's a good idea, these deductibles? We'll pay, you just have to pay the first 500. That would be nothing deductible as far as health insurance goes right now. I think in general, it dissuades people from using healthcare. If you get into a fender bender, if you got a $3,000 deductible, all right, well, is this repair really worth that amount of money? I don't know. But if your insurance said, no deductible, you'd say, shopping cart bumped my bumper and now it's a little miscolored. We're going to get that thing replaced. If it was no deductible, you'd say, fix everything. I'm going to bring it to the shop every week. So deductibles dissuade people from using whatever service that is. Co-payments and co-insurances, those are the individual that the patient has to pay per visit or even procedure. That can be complicated as well. Co-payments are a flat dollar amount. Co-insurances are a percentage of the cost. So if it costs, round numbers, $100 for outpatient physical therapy, a co-payment would say, all right, it costs $100. We'll pay, the insurance company will pay 80. You have to pay 20. Okay. A co-insurance of 25% would then be, you can go anywhere you want. These guys charge 100. These other guys charge 200, but you got to pay 25% of it. All right, well, if I have a co-payment, $20 no matter where I go, co-insurance, now I've got to figure out I've got to calculate that now. So different federal health insurance programs. Medicare, we started to touch on. Medicare started in 1965 to cover the elderly, which is typically, by definition, Medicare is 65 years and older. There are some exceptions. I think 55 if you're a widow, I think is the other one. There's some other exceptions in there as well. But typically over 65 years, you become eligible for Medicare. Part A covers inpatient services. That's hospitals, skilled nursing facilities, and some home care. My home care company, we bill under Part A. Part B covers outpatient services, which is a large amount of physical therapy services. Part D covers medications. And then there's different Medicare Advantage plans. That's an optional plan that's managed by another insurance companies, but they have to follow Medicare guidelines. So these are, I've never seen one that somebody's happy with. So if you have any loved ones that are thinking, oh, do I just go Medicare or maybe this other, Blue Cross has the Blue Cross for Medicare plan. United Health has United Health for Medicare. So basically you call up Blue Cross or you call up United Health and say, hey, I was thinking about Medicare. They'd say, well, you could do this Blue Cross or Medicare plan, and they'd sell you on how great it is. Well, what they're doing is they're just managing the monies for the government, and they're going to make money somehow. So it's never going to be, anyway, I don't want to get too deep into that rabbit hole. Medicaid started in the 1960s. That's for low-income individuals and people with disabilities, along with some other exceptions. For these federal health insurances, the name and who it covers is the big thing we've got to know. And then we have the Children's Health Insurance Program, CHIP, that was started in 1997 because there were some people that were either uninsured children and pregnant women that didn't meet the Medicaid guidelines, made too much money for that, but also didn't have enough to pay for private insurance. So it's this little pocket of people that we started this CHIP program for. So a couple of types of payment, and again, also known as reimbursement. So retrospective method, healthcare provider gets paid after the services are provided. That's the traditional method we've had. So I go see a patient, then I get to say, okay, insurance, I saw this person twice this week, please pay me. And then in 6 or 8 weeks, they'll pay me. So that's the retrospective. It already happened. You're paying me for what I did. I'm cashing this check from this payment because of what I did 8 weeks ago. Typically, it's fee for service, which is billing each item provided. Billing for each item provided is a little tricky because then, so instead of me saying, well, I did one physical therapy visit, that would be nice. Fee for service says, well, I did 15 minutes of exercise. I did 15 minutes of manual, me moving the joint or doing something to them. And then we did 15 minutes of activity, like learning how to walk again, like learning how to go up and down stairs. That's an activity, right? So we did 15 minutes of exercise, 15 minutes manual, and 15 minutes of that activity. So I'm going to charge for each all those units. What do you think happens when we, instead of me saying, hey, I'm just going to go do physical therapy for somebody and then treat them? What do you think happens when we use a fee for service, where we bill for each thing that we do? What am I incentivized to do if I want to make more money? Do more things. Yeah. Yeah. If I get paid $4 to do an ultrasound on somebody, I start doing them more. Hey, $4. All right. Patient's already here. Why not? Tack it on. Yeah, so there are some places that chase those, make sure you go for each one. And there used to be a 15-minute block code. You get paid in 8-minute increments, I should say. The 8-minute rule. You had to do something for at least 8 minutes, and then each chunk of 8 minutes you get to bill for. So then we as providers, we always tried to make sure we did the however many minutes they were there plus 1 minute, but never minus 1. So if you ever did something for 7 minutes, you say, I can't get paid. Better do it for 8. What if they only need 7 minutes? Better do it for 8. We're gonna get paid more. So we're incentivized to do more. But some costs are controlled by requiring the fees to be usual, customary, and reasonable. So I can open up my own physical therapy place and I can say, I'm going to charge $1,000 per visit. I'm the best in the world. All right. The insurance company is going to look at that and say, nobody else in your area is charging that much. Actually, the usual, customary, and reasonable in your area is $42. So we're going to pay you $42. Not going to say, but I'm the best. They're going to say, but you're $42 good. That's what we tell you. What's good about that is if we're treating in downtown Manhattan, New York City, we're getting paid a lot because it costs a lot to treat people in Manhattan. We've got the rent, this square footage. If we had our PT clinic, that's a good chunk of money in Manhattan. So our insurance companies have to pay us more because if we're in rural Oklahoma, when you can have this whole building for, I think, $37, I think is, they're going to pay us a lot less because it's cheaper to do business there. So that's nice. Prospective method, I've been seeing more and more. There's some advantages to the insurance side for it, but healthcare providers get paid in advance for providing care. So the insurance companies pays provider total cost based on this DRG, diagnostic related group. So if I've got these DRGs taking a bunch of data, okay, this person is this old, they have this BMI, they have total knee replacement is their primary rehab diagnosis, but they also had a heart attack 10 years ago. So then they come up with this algorithm, and then the insurance company says, okay, it should cost you $3,000 to treat this person. So here's $3,000. Good luck. So that's all right. What do you think some of the pros and cons of that are, though? Yeah, so if the patient, and I've got plenty of cases, but yeah, if the patient gets better fast, there's some just people that get better fast. Nice, I made some money. But if they get better slow, or if they have other things that aren't in this algorithm, anxiety, poor. One of the things with the CRGs is diabetes, right? That would be a big factor. Well-controlled diabetes, no problem. Poorly controlled diabetes, disaster, right? So just because you have diabetes, I don't know if it's going to be easy or hard to treat that person. So yeah, it's up to us to control those costs, and it can be really, really tough. I think we're also incentivized to do less, right? So over in the fee for service, we're incentivized to do more and more. Get the person in. If you think they're going to get, if we say this ankle sprain is going to get better in 4 to 6 weeks, I'm going to say you're coming for 6 weeks. You're going to come 3 times a week and not 2. And we're going to do 48 minutes of exercise and not 47, right? So in this prospective, I get paid for physical therapy. Geez, you're going to come in now twice a week because I don't want to burn all those visits, and I already got my money. I just have to manage this. So it's up to us to control those costs. So sometimes it really is up to the provider to treat morally and ethically, where our best interests are are for that patient. Same happened for the fee for service. We had to treat morally. We can't just lump more and more on. But yeah, it is up to us to control cost a little bit more, and it can be more complicated. Yep. I think it's a team effort. Um, yeah, how much does the PTA contribute to this things? Yeah, I think it's a team effort. And what I will also, I say it to the PTAs that work for me. I say it to every single student. I saw the patient day one for an hour ish. It might only be 30 minutes actually. When you see them for 30 minutes for their follow-up, who's the bigger expert? Me, who I saw them for 30 minutes at the end of last week, or you who saw them 30 minutes yesterday? I would say you now are the expert on that patient. Um, but that's where we have to be a good team. And the patient might not understand all of this finance stuff until they come back the next visit. Maybe they come back the next visit and the front desk says, "Oh, by the way, we didn't collect your copay last time. It's $40." And then today is another 40, so that's $80. That person might go, "What?" That plenty of times people didn't have any clue about their deductible, their copays. So sometimes there's a big sticker shock to that. And now you are the one who's talking to the patient, and the patient says, "I didn't realize I had to pay $40 each time." And now you're part of the team making the decision of, okay, well, what are we going to do? Yeah, that's it. And it's up to us to educate the patient and have. I mean, they've got to make their choices on what they're going to spend their dollars on. You do your own oil changes for your car, or do you bring it somewhere? Do they ever try to sell you brakes, windshield wipers? That's They're doing fee for service, by the way, right? Um, yeah, it's up to us to educate, and just like the oil change says, well, your windshield wipers look crummy. It's up to us to say, not that crummy. Get out of there. um, it's up to us to help educate our patient what we think we can do and work with them and whatever their constraints might be. Yeah. So other managed cares, so different insurances. There's a couple of versions of health insurance called health maintenance organizations, or HMOs. So Health Maintenance Organization Act was passed in 1973, allowing insurance companies to manage patients' care in 2 major ways. One, using a predetermined payment schedule, and using a provider network. So the predetermined payment schedule is basically a discount fee, and the use of the provider network allows us to do that. So I can open up my own outpatient physical therapy place tomorrow. And I don't have to work with any insurance companies. I could charge as much as I want, and I could say, you as the patient, you go chase the insurance. I'm not doing that. That would be out of network. I could also become in-network, where I apply to the insurance company. I say, I'm opening up my own shop. I'd like access to your patients. Anybody that has United Health and would like to be able to treat them. They'd say, great. Problem is, we're only going to give you $40 per visit. But we have 40,000 Rhode Islanders under our plan. So if you want access to those 40,000 potential patients, you got to take the discount. So you become in our network, and then we're going to pay you less because we're giving you access to all those patients. So that's what the major benefit, the major features of an HMO are. There are other things that they do. There's a lot of different versions of HMOs with different pros and cons in each. I think it's well beyond our scope for this class, but they all have similar characteristics with some different pros and cons within them. But they're all basically three-letter abbreviations, the last letter being O. So HMO, PPO, LMO, whatever goes on in them. I always hate teaching about this because there's some things that are important to understand and other things like insurance has changed so frequently that it's hard to keep up with as a provider, as like not just as a teacher and saying, I teach about it, I don't really do it. No, I actually do it, and it's really hard to keep up with it as a provider. It's really frustrating. One of the things that Neighborhood Health, United Health started pulling on us. So we have to do reevals of our patient every 30 days, right? We go in, we redo our objective measures. Are we making progress? Do we still need physical therapy now? We do a really good job on this. Those two insurance companies started to check our revisit notes to then authorize more physical therapy. So they give us 30 days to treat the person. And then at the 30-day mark, they'd say, give us the last 3 treatment notes and we'll decide if we need more. So I asked them, why am I doing a reeval? With all of these updated measures, if you're going to use my revisit notes to do it. That's what I mean about playing the game. Like, so now we have to do reevals on days 25 and not 30. Because then we have the objective measures to justify more physical therapy if we need. If we just do the treatments and I don't do those measures, because I don't have to do every measure every time, then like it's just their way to say, oh, there's no objective progress here. Yeah, because I'm doing the progress tomorrow. Like give me a day. No, we're not going to authorize it more. So anyway, that's one of the new games they've been playing. And that just happened in the last 6 months. They started pulling that with us in the home care world. So yeah, it changes quite a bit. But the health maintenance organization is the big features of it is the in-network provider, but accepting a discount rate to do that. The way for the insurance companies to save money. One of the other ways that health maintenance organizations and different insurers limit the payment. The insurances call it loss, which is like, no, I paid you so that I could use healthcare. It's not a loss. Like I paid you. But one of the other ways they prevent physical therapy is they put a limit on number of visits allowed per year. So I'm sure you've seen it, Rogan and High Bar. This person only has 12 visits a year. And they don't authorize all 12 off the bat either. So, no, you have 12 for the year, but we'll only give you 4 for now. Yeah. Yeah. Yeah, and I already used 3 for my sprained ankle last year, or 3 before I was trying not to have the surgery, and I used 4. Yeah, but yeah, so they put in limits of the number of visits per year. Sometimes it's dollar amount instead of visits. That's a same thing but different. That the catch-all term for that, and I wish I put it up here, is called capitation. You might see that capitation. And if you hear, you might even hear this at work. Would you hear them say, "Well, what's the cap?" Yeah, that's what we're talking about is what is the limit? What is the ceiling of we can do? Sometimes it's visits or dollars. Do you ever hear dollar amount or just visits? Just visits. So So other payment trends, consumer-driven health plans, high deductible plans with health savings options. That's what I was talking about at the beginning in class, right? These $5,000, $10,000 deductibles, high deductibles, with also as health savings options. So you get pre-tax dollars put in a special bank account that's only for healthcare, but it's pre-tax dollars, so that's nice. The value-based healthcare has a range of incentives to reduce costs while also improving patient outcomes. So how we measure that, more pay for better quality of care. Few different things requiring evidence-based medicine, patient satisfaction scores, removing incentives to perform more procedures. That's that fee for service. So, all right, let's take that out of the picture, and now it matters less. So there's a lot of things that this impacts me as a clinician quite a bit. I've seen this as well. And yeah, we have patient satisfaction scores that dictate how much we're going to get paid. It doesn't swing it a ton, but when you're operating a business, 2%, if you're billing $2 million a year, which is not that much for a small to medium practice, yeah, 2% of 2 million, it's a chunk of change. That's a chunk of change. And for me, the patient satisfaction, my patients are always happy with me. I would say that's probably my strength as a clinician, is like connecting with people and having them enjoy the process of physical therapy. But we get dinged on the weirdest patient satisfaction scores, and sometimes it's not our problem. Like, they have a CNA from a different company, but when the patient does their surveys, they mark us down for that CNA being late. But they're not in our company, and they'll write in the words CNA is always late. Okay, I don't like it when she makes grilled cheese. Like, I don't like how she does it. Like, the weirdest thing gets shown up in the patient satisfaction, and that I think in the world of online reviews, we can all see that some people are just never happy. Like, I ordered the blue bike and this is too blue. Like, people rate things for weird reasons. So I always have a little bit of a problem with that. But anyway. So general enrollment trends, employer-sponsored health insurance covers 153 million people in the United States. So I think that number is actually higher now. So right around half of the United States, half the population of the United States is covered by an employer-sponsored program. Vast majority is in some sort of HMO, PPO version, with 30% in a high deductible plans with that savings option. That's quite a lot. So I'll just pause here. We're going to talk about this again later, but that high deductible plan, the savings option, I've got a lot of friends who are opening cash-based businesses, because if you're going to bill through insurance, you have to either pay someone else to chase down the insurance monies, or you have to hire a billing manager to chase down those monies. It's really tough to manage as a solo practitioner. There are companies out there that'll do it. There are companies out there that say, we'll handle all of your billing. We'll just take 10% of whatever you bill. So if you're a small practice, that's not that bad. Once you become medium size, actually, even if you're a solo practitioner, if you're billing a full 40-hour week, now hiring somebody in-house might be more beneficial. But I have plenty of friends who are opening cash-based businesses. We don't go through insurances at all. You pay directly, because these people with high deductible plans with savings options, if you're young and fairly healthy, you have a $10,000 deductible, you're basically betting on not needing healthcare then. But if you have $4,000 in your health spendings account, geez, what's $4,000 divided by 12? What is that? What is that per month? $330 a month in these health savings accounts. You could buy anything you buy at CVS, you could buy with that account. But I've got friends who they have it's basically an advanced gym membership. For $300 a month, you can come in here, you can exercise, you can get physical therapy twice a week for $300 a month. Boy, that's pretty good. Guaranteed monthly, like we're not chasing patients. Hey, if you're hurt, come over here. I hope you're hurt. Are you hurt? Come here. Like we're basically the people that are doing that are taking a really active role, almost like a super personal trainer, and it's a really interesting way to do it. Man, if 30% of the US population has a high deductible plan with a savings option, that's a chunk of patients that you could tap into. And guess what? Those patients are incentivized to be healthy, because if you're not healthy and need to start using healthcare, you got a problem. So how do we do that? Exercise a bunch, work with a physical therapist assistant, keep yourself healthy. It's a really interesting, fairly new market. I've got two friends that have both their practices are older than what I could. They're over 5 years old, so that they're not brand new. I think one of them. I think both are close to 10 years. So anyway, it's an interesting field that we can be in now. Well, we'll get into it a little bit later, but let's look at other factors that contribute to rising healthcare costs. Advancements in medical technology. New technology is expensive to use, so it costs more to use it. Asian population increase, prevalence of chronic diseases. Increased utilization of healthcare services, more people have access to healthcare. Rising drug prices. Part of the reason health insurance is so expensive is because it's expensive to run this, so we have to add on administrative costs. That's what I was just saying about if you're going to be a full-time practitioner, then you might need to hire someone just to handle the billing. Well, that makes it more expensive just to do business. That's not really what I wanted to do here. Medical malpractice and liability costs, hospital and provider charges. Consolidation of practices leads to less competition. That is a huge problem across the country. Areas that there's a lot of competition leads to improved pricing. It's for any industry. So when we only have 2 or 3 drug manufacturers in the United States, there's no incentive to keep price down. That's actually one of the fallacies of generic drugs. If this high blood pressure medication costs $100 a pill, if I invent a generic version, there's no reason for me to charge much less than $100, because they're already getting $100. I'll charge 90 and say it's generic. We'll give you a discount, but it's not really an incentive to charge less. If there were only 2 options for cars, one of them cost $100,000. Well, if I'm the other car company, I'm going to say, we'll charge 90 and we'll say we're cheaper, but why would we be less? There's only 2 options. So consolidation of competition is a problem with all pricing, and healthcare is no different. So different cost control measures, shifting cost to the individual. So us, high deductibles, co-pays, co-insurances. In retrospective control, it's what is usual, customary, and reasonable. Prospective controls is use of those diagnostic related groups. Value-based care is important, right? So if my patients aren't happy with me, the insurance companies will start paying me less. And different in-network policies. So some different impact us on in physical therapy in particular. So, one, we have to understand insurances. Like, so this part really sucks. Like, we have to learn everything about the body, how to get people better, how to listen to people, how to connect with them so they get them to moving. Do all of these advanced special skills and knowledge and thinking. Oh, yeah, and also learn all this insurance industry stuff. Big, big problem. But we have to because it impacts our patients, right? And if my patient says I can only come once every other week, how are we going to adjust our care to do that? So we have to understand it. Big shift in value. How do we improve the patient in the shortest amount of time? Big shift to cash-based practices, avoiding reimbursement altogether. That's one couple of things I was just talking about. And that's it's a completely different perspective than the physical therapy world. Instead of chasing people who are in pain or after surgery and saying, we'll get you back, there's a big shift in don't get hurt in the first place. And how do we do that? It's much different. Um, yeah, it's different. It's very different. I think we've talked in this class how I talk to my patients about nutrition, and if you need to lose weight, these are the reasons for it. Here's a couple resources for it. Have I talked about that in this class? No. There's a conversation I have with a lot of my patients, right? So, what are our outcomes? Return to prior level of function, hopefully, improve current level of function, definitely, and then minimize future consequences. Well, our patients' size is a big problem. Like it's cardiovascular taxing, poor sedentary lifestyle, poor nutrition. 25% of Americans will die because of some sort of cardiovascular disease. So, man, if we can start talking about those things, we've really impacted that patient's life. And if every physical therapist, physical therapist assistant does that, we can impact the health needs of society, which is one of the values that we have. Um, so I talked to my patients about, listen, you have this arthritic knee. I had a patient not too long ago. Arthritic knee, um, he was over 400 pounds. He needed a knee replacement, but nobody would do surgery on him because he was over 400 pounds. And I think if he got to 300, somebody would do surgery on him. Like you can be obese and still have, but not to his level. So before I left, we got him his goals. He was in and out of the house again, back to having breakfast with the fellas. And before I left, I got to have a tough conversation with him, man. This knee isn't going anywhere. It's an arthritic knee, and the size that you are is only compounding the problem. If you lost some weight, you would then start being able to, doctors would entertain the idea of doing a knee replacement for you. And also, man, if you lost 100 pounds, I wonder if you would need a knee replacement. Like, I wonder if taking off that load would be just enough so you don't need a knee replacement anymore. I don't know. I can't say that for sure. But I've had some patients lose 20 pounds and think I don't need surgery anymore. So I've had other patients lose 50 and still need a knee replacement. Don't get me wrong, but man, you might fit in that category if I don't need it. So I have those conversations with my patients all the time, but that's what they are. They're conversations, they're guidance. I'm not my primary problem is getting this guy in and out of the house, not having him lose weight. If you're in a cash-based practice, that now becomes your primary thing. That's now the thing you're talking about. So you're talking about nutrition all the time, those cash-based. Anyway, it's just a different way to operate. Added pressure to prompt for fast discharges to fit within pay structure. Medicare, the way Medicare changed their payment just a couple of years ago for our home care services is they said, okay, for the first 30 days of service, we'll pay $150 per visit, making those numbers up. And the second 30-day period, we're only going to pay $120 per visit. And if you do another 30-day visit after the 30-day chunk after that, up to day 90, we're only going to pay $75. Well, what they're incentivizing us to do is treat a lot early on and then stop treating. Like, don't treat forever. Um, so prompt discharges. I talk to my team all the time. Our goal is 4 weeks for every single patient. Our goal is 4 weeks. Now, we still want you to be good clinicians. If your patient needs more, we're going to do it. We want to be good clinicians. That's something special about my company, the size that we're at, and our caring clinicians, that we always want to do a good job. We'll always rather do a good job than a bad job. But our goal is every 30 days. And we have meetings every 2 weeks, like I said last week in our team models, every 2 weeks. And we have it coming up on Monday. I just ran my reports. Here are all the patients that are above 30 days. Why are we still treating this one? Why are we still treating this one? Why are we still treating this one? There's plenty that we do, but we got to know why and what are we getting out. So yeah, that's prompt discharge. It's also for that prospective method of payment. The faster you discharge, the more money you're going to pocket. So, there's added incentive to discharge quickly. Potential increase in telemedicine to reduce costs. That's an interesting option. Some insurances will pay for it. So, do I need to see every single person 2 or 3 times a week? Or some of these people, can I see once every other week in person and once every other week virtually? Brooke, if you think of those total knee replacements, how many of them you could just check in with the video call once every other week and then see them in person for the first, that first phase when it's just a bunch of knee bending, and we could monitor that at a distance. And now we only get 8 visits from United Health for this chunk. Now all of a sudden, if we're only seeing them in person every other week for the first, we've only used 2 visits in the first month, and at the 1 month mark, now we get to start pushing that patient. Now that's something we can actually say, okay, like this, we can work around this, right? Not every patient, but like that's something we can start to do. One of the other things, I know of one PT that does 100% of her work as telemedicine. Pretty interesting. But what's great about the potential of that is work from home days. I think obviously there's been a big shift to work to home. And in physical therapy, that's basically, well, no, we can't do that. But I think there's some patients we can. I think there's definitely some patients we can. You ever see the rotator cuff repairs that just stuck like this for the first 8 weeks, and then we can just check in with. If I can get $5 for a 5-minute phone call with them, video call. I just got to check in with them for the first 6 weeks until they can start moving, and after that we could go. But so there's some options there. Again, I know one PT that's all she does. Pretty interesting. So here's a couple of acronyms that I want to make sure that you guys know. Let's go back to these learning objectives. All right, different payers than respective subscribers. All right, so different payers, what insurance payers were there? It was the federal ones, right? That's one of the payers. And then the different payers, the other one, the category was the health maintenance organization. Those are commercial insurers. 2 different types of insurance reimbursement. What were they? Retrospective and prospective. Retrospective is I did something and then I please, can you pay me for that? Prospective is I'm about to do something, pay me for that. Yep. History of reimbursement. Any major facts that stand out of history of reimbursement, history of healthcare? So it started with the barter system. And then why did health insurances basically get created? World War II to attract women in the workforce. Yeah. Yeah. Yeah, those are the major history of reimbursement. Why have healthcare costs escalated? What are some main reasons why? Technology increase. Yep. What else? Aging population, big reason. Access to care. Specialization is another big reason. Yeah. Yep. What cost control measures have been implemented? So we talked about a handful of them. Deductibles, co-pay, and co-insurances. Capitation. That word for you only have so many visits or dollars per year to spend. Um, in-network features, in-network discounts. What was the other thing you said? HMOs, yeah, HMOs. So that in-network for a discounted fee. Those are the major ones. Common acronyms. What were they? I skipped that. So one of them was CHIP. What was CHIP? Yeah, so it's the I'm blanking on the what it stands for. Children, yeah. Children's Health Insurance Program, good. Yep, so that's federal insurance for uninsured children and pregnant women with some other exceptions, but that's the main. DRG was another one. What was the DRG? Diagnostic related group. So that's the algorithm that the insurance companies figure out how much to pay us. That's how they predict how much should it cost to treat a person with those problems. I think HMO was the other abbreviation. Yeah. What's HMO stand for? Health Maintenance Organization. Yeah. All right. Do we have any questions on today's stuff? Yeah. Yep. Oh, yeah. The question was if you sign up for a job, they say, oh, we'll pay you 60 grand a year. Does that ever change? So really tough question to answer. The answer is it shouldn't really, but it can. Um, so for home care for me, my PTs and PTAs are expected to see so many visits per week. And if they don't see those visits, they have to use their vacation time to do it. So if you're supposed to see 30 visits and you only saw 28, you're using 2 hours of vacation time this week. That rarely happens. But if you're supposed to see 30 people and and then we were busy and you chose to see 32, you get paid more. So um my company handles it. So if it happens once in a while, not a big problem. Don't worry about it. If it's happening often, we got to figure out why. Like, why are your patients always going to the hospital? Why are your patients always canceling on you? Why are your patients like, what is it? But I mean, we have plenty of patients to see. So it you know, if somebody canceled on you, if you knew Friday morning somebody canceled on you, I can find you a patient to see on Friday. We can get that number. Um, so we're a small home care company. I know in the outpatient world where I used to work in, they paid me 60 grand for the year, and I could make more than that, but I wasn't going to make less. That's yep. So I mean, there's different employment set up as well. We have per diem, which is basically if I need you, I'll call you. We have part-time, we have full-time. If you're full-time, there's the major ones are full-time salary, full-time hourly. So those are, yeah, but basically you should be guaranteed that dollar amount at the end of the year. Yeah, that's what it should be. If I always question, like you said, it's not in my control whether the patients show up. To some degree, it is. If you have the highest cancellation rate of the whole practice, all right, there's something with you that why they're canceling more. But yeah, there's some other stuff that plays into that. So the only times we've had patient shortages in my home care company is when we hire new staff and then we need to fill up more. So like we're growing and we have some of the growing pains. That's the only times we've had a shortage of patients. It rarely happens. It might happen for a week or two in a year, but it's odd when it happens. Yeah, the only times we've had it's growing pains when we hire two new staff and we haven't quite done enough marketing to fill up their schedules. There's always that growth, just like what you're going to experience at the new place. Like we have this extra square footage. We need to grow to justify the square footage and added costs, and there'll be some short-term pain because of it, but we'll grow. Yeah, yeah, nice, nice. So, any other questions about today's material? Stop this. Good luck studying.